A very warm welcome to everyone. I'm delighted to have you all join us today for this enlightening session, Breaking Barriers in Cancer Care, Exploring the Role of Pharm.D in Oncology, which is going to be hosted by Society of Clinical Research and Medical Professionals, SCRMP. Today, I'm here, Sidra Fatima, the Director of Strategy and Planning at SCRMP. I'm honored to be your host for this event. As a PharmD student myself, this topic holds a special significance for me, making this session an exciting and meaningful opportunity to explore the evolving role of our profession in oncology care. Today's discussion will focus on the significant role of PharmD professionals in advancing cancer care, covering their contributions to patient management, therapy optimization, and cancer treatment, as well as its innovations. Before we begin, a quick introduction to SCRMP. SCRMP, Society of Clinical Research and Medical Professionals, was founded in 2024 and is based in Telangana, India. SCRMP is committed to advancing clinical research and supporting healthcare professionals. Through workshops, webinars, and our publication, Health Kingdom, we promote innovation, collaboration, and education in clinical research. We invite all the attendees to explore our membership options, which offer exclusive benefits such as internships, educational resources, and networking opportunities, helping enhance your professional journey and contribute to a global vision for a better healthcare. Since it's all already time, let me introduce you all to our speaker today. It's my honor to it's my honor to introduce today's speaker, Dr. Neha Tabassum. Dr. Tabassum is a distinguished research scientist and teaching fellow at Imperial College London, specializing in cancer genetics, bioinformatics, and molecular biology. She holds a PharmD, MBBS, and a PhD in clinical medicine research and is also a fellow of Higher Education Academy, FHEA. Dr. Tabassum has made significant contributions to cancer research with publications in top tier journals such as Nature Communications and Oncology. Her expertise bridges clinical practice and scientific discovery, advancing our understanding of cancer at molecular level. We are privileged to have her today. She is also a senior scientific writer at Skywalk Consulting with expertise in scientific communication and NGS data analysis. Dr. Tabassum has earned awards such as the Best Speaker Award from the Royal Society of Medicine and Excellence in Bioinformatics Award from the Wellcome Genome Campus and advocate for cancer awareness. She developed the Impact online elective and is an active member of AACCR, EACR, and BACR. Dr. Tabassum's expertise makes her the ideal guide for today's session, Breaking Barriers in Cancer Care, Exploring the Role of PharmD in Oncology. Without further ado, please join me in welcoming Dr. Neha Tabassum. Over to you, ma'am.
I think I'm on mute. Thank you for the introduction, dear. Good evening, everyone. It's an honor to be here today to discuss a topic that's rapidly transforming the landscape of cancer care, the evolving role of pharmacy professionals and pharmacovigilance. So the role of family students in precision medicine is precision medicine basically leverages the molecular diagnostics, genomic sequencing, let's say, and biomarkers to identify unique characteristics of both the patients and the tumor. Now, this enables the targeted therapies which are designed to attack the cancer cells while sparing the healthy cell. For example, these therapies targeting HER2, let's say in case of breast cancer, HER2 in breast cancer or BRAF mutations in melanoma have revolutionized the outcomes of the treatment of patients. Now, when we talk about patient-centered approach, now at its core, personalized cancer care is about patient, all about patient. It shifts the focus from treating the disease to treating the person with the disease. Now, this approach requires a multidisciplinary team, and this is where PharmD professionals shine. They integrate the pharmacological expertise into patient-centered strategies here. Now, expanding the role of Pharm.D in oncology, pharmacogenomics and precision medicine is one area. Pharmacogenomics, it examines how a patient's genetic profile affects their response to the drugs. They're two individual patients, but they react differently to the treatment, to the same treatment. For example, there is a variation in the TPMT gene can influence the metabolism of thiopurines, which are used in leukemia treatment. Now, this requiring dose adjustment to prevent the toxicity, Pharm.D professionals play a critical role in interpreting this pharmacogenomic data and guiding the therapy area. So, whenever you're treating a cancer patient, it's a multidisciplinary care you're offering that patient. As we have discussed in clinical pharmacy role, pharmacist role in pharmacy practice and oncology, where we say that the most commonly affected organs are the renal system and the hepatic system of the patient. So you're also involving nephrologists in it to treat the patient. So Pharm.D professionals, they work alongside the oncologist, nurses, and genetic counselors, participating in tumor boards, contributing to clinical decision making, and advocating for evidence-based medications. So when I say we are advocating for evidence-based medication, it doesn't mean that I know everything about the drugs. I go back to the researchers, the latest peer-reviewed research papers which are published by the clinical scientists, let's say clinicians, if they have come across any rare case and published some study case reports, case studies and all. So I'm going to go there, look for evidence, and then come back to the clinician and suggest that, like, look, the patient is having these comorbid conditions, or the patient is suffering from drug-drug interaction. What if we treat the patient in X manner? Because we have gotten evidence from the peer-reviewed journals. So this is where we play as an important role in kind of providing evidence-based practices to the clinicians, nurses, and the genetic counselors as well. Another third is case studies and real-world applications. Now let's say an example of case study one. Now consider a patient with non-small cell lung cancer, okay, NSCLC. So genetic testing reveals that EGFR mutation guiding the use of targeted therapy with alotinib instead of traditional chemotherapy. So that's the standard care, which is proven by the evidence, which has been published in quite a lot of papers in like very renowned journals, let's say like Nature, Lancet, Cancer Cell, and all. So the Pharm.D professional, they kind of ensures the appropriate dosing, managing the side effects, and monitoring for the resistance. What happens if the drug is given for a very long time into that patient? Is the patient developing any sort of resistance? So this is where we kind of play an important role in such situations. Let's look into the second scenario. A patient on immunotherapy develops immune-related colitis, okay? So the Pharm.D professionals, they identifies the adverse reactions quite early. They recommend corticosteroid management to the patients. I'm sure you all are like much intelligent than me, you know much better than me. You know, like you can recommend corticosteroid management for these patients and adjust the immunotherapy schedule in collaboration with oncologists. So it's not just, we always have to remember we need to acknowledge what we can do and what we can't. There's a lot of misconception in many of the Pharm.D professionals that we can prescribe at one point, maybe let's say in a year time or 2 years time or in 10 years time. So please remove this illusion from your head. We are no way related to prescription, okay? We are never going to prescribe. We will never get the right of prescription. We will always recommend the schedule of the patient, recommend the dosage of the patients in collaboration with the clinician. So whatever kind of suggestions we are given, it will always be in collaboration. In case of oncology, we are in collaboration with oncologists in improving the patient's outcome.
And Dr. Thallapudi has specialized in oncology pharmacy, conducting medication reviews, resolving drug related issues, and optimizing patient care through clinical rounds. With a Pharm.D. from Aditya Educational Institutions, Dr. Thallapudi is committed to patient education, improving medication adherence, and contributing to oncology pharmacotherapy education, clinical research, and multidisciplinary healthcare teams. Without further ado, let us welcome Dr. Kalyan Thallapudi to the stage to share his insights on today's webinar.
Every day we will face different challenges in the pediatrics by in AML and ALL cases. So, as a clinical pharmacist, we should monitor carefully while tapering the dosage. And difficulty in adherence, because some kids may refuse to take the medication. So we need to do it by changing it to the normal saline with dilution procedures. And, uh, next slide. Yeah. Coming to my daily routine as a clinical pharmacist. Next slide, please. Every day morning, I'll do the chart review before my consultant arrive to the ward, and I will identify all the drug interactions and I will note it down. When after 9:30, when my consultant came, we the team will join the multidisciplinary round with dietitians, DMO, psychologist, and clinical pharmacist. Uh, After in these rounds, he will ask everything regarding the prescription chart, whatever the particularly he will ask the clinical pharmacist that if you found any drug interactions, please let me know so that I can minimize the doses. And also uh, we need to hello.
Yes, sir, please go ahead. We are listening.
Yeah. After completing my rounds, I will, if any patient is having the chemotherapy, I will go through the drug dilutions and documentations of if any areas are found. I will documented that. And after at post rounds, after if we find any toxicities when the patient is in infusion with the chemotherapy, we will found it and note it down and report it to the concerned consultant, so that we will write an ADR form and we will file it for the future treatment, for further treatment, actually. At after 3 p.m., after all the clinical pharmacists will gather in our department room and we will discuss what are the areas we found it today, and we will try to discuss with the consultants and to change the medications for to minimize these errors. Next slide, please. Yeah. So coming to the daily challenges, every clinical pharmacist will face these daily challenges while we need to check the interactions as well as dilutions as well as rounds, patient doctor rounds, and intention versus reality. Here we can see that uh, as per the doctors will write the schedule, we will think that prescription need to be followed in this way, but sometimes due to in hurry, sisters might be do some errors there. We might be in busy in by dilution or in doctor rounds, so we need to
Myth. This segment will provide a deeper exploration into common misconceptions surrounding the cancer care. So, for the segment 2, we will be
Nutritional values. The World Health Organization and the US National Academy of Sciences have concluded that genetically modified foods currently on the market, they are safe to eat and not associated with increased risk of cancer. There's also a review which has been published in Lancet with 1,700 studies which have found that there's no adverse health effects which is related to genetically modified food consumption. Now, consider widespread use of GM crops like corn and soy. I mean, like this is very common nowadays in the global food supply for decades now, without any linked cancer outbreaks or trends. So, to conclude, I would say it's still a myth, especially after shaving. So most of the pubic areas, like underarms, let's say, they kind of, shave it and then apply the antiperspirants or the deodorants, and they kind of cause harmful changes in the breast cells. However, there's no scientific evidence which supports this claim. It might be correct. I mean, I'm not denying, but this is a myth because we as educated professionals, we rely on evidence. and there's no scientific evidence which has been, shown to claim this thing. Now, again, coming back to American Cancer Society, they state that there is no conclusive evidence linking the use of antiperspirants or deodorants with the breast cancer. A large review has been published in the Journal of National Cancer Institute, which I think have involved like more than 10,000 people. They've found no connection between this antiperspirants or use or breast cancer risk. So millions of people use these products daily without any proven increased cancer risk. Breast cancer is more strongly linked to the genetic factors like mutations, lifestyle choices, and environmental exposures, but not to this antiperspirants or deodorant. So for me, it's just a myth. And I'm sure like after listening to the evidences, you will also agree that it's a myth. There's no link between emotional well-being and survival in head and neck cancer patients. So patients with a positive outlook may handle the stress of illness better, but they still need evidence-based medical treatments to manage or cure their cancers. Now, I hope this clears that it is not a fact, but it's just a myth again. Again, a myth. It's not a fact. While family history, it can increase the cancer risk, it does not mean that you will definitely get cancer. There's only about 5 to 10% of cancers that are strongly hereditary, which is linked to specific genetic mutations like BRCA1 and BRCA2 for breast and ovarian cancer. So if I have BRCA1 and BRCA2 mutations, my progeny, my kids, are most highly likely, like there's like nearly 10% of increased risk of my kids having that BRCA1 and 2 mutations in them. But the rest of 80%, 90%, they're free. I mean, like, there's no risk for them. The majority of cancers are caused by a combination of genetic, environmental, and lifestyle factors. Like cancer doesn't really strike with one mutations in your body. There might be BRCA1 mutations in me. I mean, like, for instance, like my father had cancer. So it could be possibly that I also have that mutations in me. But if my lifestyle is really bad, I'm kind of smoking, having alcohol all the time, I'm under stress, like stress also increases the risk of cancer. I'm under total stress all the time. And I'm doing some really like, I'm really kind of adapting to very much risk factors, environmental risk factors. Then there is a high chance of me getting cancer. Just by seeing that my father had cancer, I'll have cancer. This is wrong. I mean, it's not completely correct. Even in family with strong histories, I've given you my personal example, but even in families with strong personal histories, lifestyle choices like smoking, as I mentioned, maintaining a healthy weight, regular screening can significantly reduce the risk of them having cancers. Angelina Jolie, I'm sure like you all are aware of this beauty queen in Hollywood. Angelina Jolie's decision to undergo preventive surgery due to her BRCA1 gene mutation. This lady didn't have cancer. She did have ancestors had BRCA1 mutations. They had breast cancers. But this lady, because she had BRCA1 mutations, she thought like because she's into that environment where she kind of smokes, where she has like alcohol consumptions and all, like she kind of highlighted the importance of genetic risk awareness. She had a surgery, trust me, she had a surgery for her breast cancer despite of her not having breast cancer. Now that kind of highlights the importance of genetic risk awareness among people these days. However, most of the people with a family history of cancer, they never develop this disease, and many cancer patients have no family.
No, not all the people are fit for the same cancer treatment. As the effectiveness of cancer treatments can vary depending on a person's age, health, and other factors. Yeah, doing the biopsy procedures like that because they will do in very hygiene conditions and maintain the surroundings very well. So it will be done in very hygienic and good protocols.
Okay, so
So
it's all
that's
in
not
these.
there is no chance of coming like that.
So it's basically a myth since the everything is
Yeah,
done in a very sterilized condition
yeah,
and
yeah.
with a lot of